it's a rare disease which originates from the somatic mutations in the X-linked PIGA molecule within the hematopoietic stem cell, PIGA receptor. And it is a prototype of the non-malignant clonal disorder, which is characterized by complement-mediated hemolytic anemia. And the disease was described as early in the later half of the 19th century. And this is the our current understanding of PNH uh, is kind of depicted in this cartoon, where we know that there would be the dividing hematopoietic stem cells would have certain cells which would acquire a PIGA A mutant during the course of division, and when they sustain whenever there is an immune attack, well, the ones who have this GPI anchor protein, they would be, the normal cells would kind of get recognized and damaged, destroyed. However, these mutant clones would kind of evade the immune attack, and finally they would clonally expand, and in the time course they may acquire further mutations. And this is the model of the two-step hypothesis of PNH pathophysiology. And we all know that as a result of PIGA mutation, these patients are deficient with the GPI receptor, and they would, as a result, they are at a higher risk of complement-mediated hemolysis. So the current international classification of PNH uh, kind of guides us to divide PNH into three major subtypes. The first is the classical hemolytic PNH, where the clone size is typically more than 50%, and these patients have an active intravascular hemolysis and or thrombosis. The second one is the PNH-associated bone marrow failure, where typically, or an MDS, where typically the clone size may be somewhere around 20 to 30%. However, the picture is dominated by cytopenias and symptoms related to that. And then there can be subclinical PNH, where the clone size is typically less than 10% without any evidence of hemolysis. However, we all understand that these are all kind of overlapping entities, and the patients can evolve from one entity to another during their course of treatment. And this is what our experience is, which I would talk about in few seconds or minutes. So how to recognize a PNH? These are the typical symptoms. They can be quite non-specific sometimes, such as dysphagia, pulmonary hypertension, dyspnea, abdominal pain due to the nitric oxide steal. They can have chronic kidney disease in a significant fraction of patients, erectile dysfunction, hemoglobin urea around 26%, thrombosis, what has been described, is around 40%, while majority of them will have anemia, around 88%, and 96% will complain of fatigue and a poor QOL. So PNH, as we all know, is actually the game of clones. If you usually have a 3 to 5% type 3 PNH RBCs and around 20 to 25% on granulocytes and monocytes, that is usually sufficient for the patient to develop some biochemical evidence of hemolysis, which is typically in the form of raised LDH or low haptoglobin and a high retic count. Once the type 3 RBC PNH clone becomes more than 20% or around 60% clone in the granulocytes and monocytes, the patient typically would develop a gross hemoglobin urea. And for development of thrombosis, what is typically said is that usually they have a clone size on granulocytes which is more than 50%, and thrombosis is a frequent cause of mortality, at least in the Western literature. So the coming to the Indian scenario, the original reports for identification of PNH somewhere came in around 1990s. This is a paper from the Apollo group in Hyderabad in 1992 in Acta Hematologica, where they described 11 patients of PNH, and they kind of compared the PNH with the Indian PNH with the Caucasian group, and they said that the patients were younger, they had a marked male preponderance. This male preponderance has been shown in a couple of studies from Asia, from Thailand and China, and few initial reports from India as well. And in the initial reports, it was believed that most of the PNH patients were the clinical scenario was being dominated more by the cytopenias, such as thrombocytopenia and hemorrhagic complications from thrombocytopenia. Though thrombosis was noted, but it was not as prominent. So this was the initial report. Then coming to this is another important large data set of around 120 patients of PNH published in 2021. This is from the AIMS New Delhi group, where they set, in their setup of patients, the almost 60 to 70% of the patients were actually AA-MDS overlap with a subclinical PNH clone, whereas around 35% were having the significant PNH clone and an AA-MDS, while classical PNH was seen in around 20% patients. Thrombosis was reported in the classic PNH group in around 25% patients, and in the AA-MDS, they had one patient who developed thrombosis, while the rest of the findings were more consistent with a typical aplastic anemia type of clinical phenotype. So what the AIMS experience has been, and this is kind of one of the largest Indian series that says that even in the Indian subgroup, as we all know, that we have aplastic anemia, which is more common in the Asia Indian population as compared to the Western population. And here they reported that we were having a higher PNH clone size as compared to what is typically seen in the Western PNH-A overlap cases. And they also kind of suggested that the Indian aplastic anemia PNH patients may remain asymptomatic despite large PNH clones with respect to hemolysis and thrombosis. So this is another kind of case series of 20 odd patients from our center in 2022, where we looked at the markers of thrombin generation and inflammation in patients with PNH, and we typically try to concentrate on the evidence of thrombosis, how frequent was it and what was the type, and the study kind of support the idea that the thrombin antithrombin complex were significantly raised in patients of PNH as compared to controls. And in this case series, I would say there was a 17% incidence of thrombosis, which was reported in a 20 patient series. This is another important. This is one of the few clinical outcomes directed papers which came in the pediatric blood and cancer, where the AIMS group talked about their experience of pediatric PNH in a resource constrained setting. And I would like to draw your attention to the kind of treatments which most of our patients are getting, which is only typically restricted to cyclosporin and androgens, antithymocyte globulins, steroids, and around 2 of the 18 patients of classic PNH undergo a stem cell transplant. Again, the PNH-AA patients were more frequently given the typical immunosuppressive therapy with ATGs and cyclosporin. So this is kind of the so when Dr. Riaz asked me to kind of talk about the Indian PNH scenario, I thought I would just look at what is happening at my center. So I tried to retrieve the data of previous 5 years of patients who were diagnosed with a PNH clone of around more than 5% of age more than 12 years, and excluding the inherited AA or the ones with where the data was not available. So this is more of the classic PNH or a bigger PNH clone uh, data. And here the median age again in this cohort is 32. The male is to female ratio is kind of similar, and I don't think the initial hypothesis that there is a higher male predominance holds true. The what is again to be noted is that there is a significant delay from the symptom onset, which is typically an anemia requiring transfusion, to the actual diagnosis of PNH, around 13 months in our case. Around one third of them were having a classical PNH phenotype, while 77% of the patients had a AA-PNH overlap kind of a phenotype. The median clone size is depicted here around 30 to 40% in the white blood cells, hemoglobin 6.7%, hemolysis evidence in 66% patients. Again, look at the treatment which they are receiving. 73% of them are actually receiving only ATG cyclosporin danazole, and around 26% patients are getting intermittent steroids whenever they have an exacerbation of their hemolysis. Around 3% underwent a transplant. So, if looking at the hemolysis and transfusion requirements, 70% when around 70% of them were actually requiring transfusions intermittently when they were followed up last, and 63% were having the evidence of hemolysis. Around 7 patients in this cohort actually had a renal impairment, which was mostly due to a pigment nephropathy, which they developed due to hemolysis, which was in 1 or 2 patients. It was actually being exacerbated by the ongoing cyclosporin use. In fact, one patient who was having a AA-PNH overlap, where the aplastic anemia had kind of responded. However, the PNH clone continued to grow, and she succumbed to a hyperkalemia, which was kind of a contribution of probably cyclosporin as well as pigment nephropathy. Around 10% patients did require a dialysis during their lifetime, and the mortality attributable to renal failure was also not less. It was around 12%. So, coming to the thrombotic events, so the prevalence of thrombosis in this cohort was around 26.7%. 8 patients had thrombosis. The commonest site of thrombosis were kind of abdominal, mesenteric vein, portal vein, and scrotum. Few others were lower limb, internal jugular vein, and superior sagittal sinus. There were 2 arterial thrombosis. One who had a cerebral artery thrombosis, a lacunar infarct, and the other one who had a celiac artery thrombosis. So of late, with the hematologica papers which said that probably NOACs can be prophylactically used, we have a kind of in select group of patients we have started using NOACs as well. So primary prophylaxis, we are resorting to patients who have a clone size which is more than 50% and do not have a contraindication to giving anticoagulation. They do not have a thrombocytopenia or a splanchnic vein thrombosis with collaterals which can predispose them to varices and upper GI bleed. So around 13% of the patients currently are in our center are on primary prophylaxis, while 23% of them are on therapeutic anticoagulation. Most of them are on vitamin K antagonist, and with one of them on rivaroxaban. So this is kind of our survival, it's around at the 10-year mark, it's around 70%. The mortality is around 23% in our subgroup. I tried to kind of interrogate today morning whether the ones who had thrombosis actually were faring worse, and it's kind of as expected true. The ones who had a thrombotic event were having an inferior survival, which was almost reaching the statistical significance was 0.054, almost nearing a statistical significance. So this is another. So this is all the previous 3 or 4 papers which I have talked about from India are actually from the northern part of India, and this is from the Dr. Neeraj Siddharthan's group. This was a poster abstract in ASH 2024, where they talked about the clinical characteristics and outcomes of patients with PNH from southern India. Again, a very similar data set, which like what we share. Steroids around 30%, CNI is around 50%, 10% getting ATGs. Hemolytic manifestations more common than thrombotic manifestations, around they had a kind of lesser incidence of venous thrombosis, around 13%. Ours was around 23%. The At 10 year, the 10-year survival was as low as 33%, and 2 patients underwent a stem cell transplant in their cohort of 45 patients. Both of them unfortunately succumbed. So this is so what we have tried to do at our center is we kind of through the Regeneron company, we kind of got an opportunity to participate in this trial, which was until last month recruiting patients randomized to a newer complement therapy, which is pozelimab with a signal interfering RNA, cemdisiran, and they were comparing this to the standard of care, which was either a ravulizumab or eculizumab. And this is the kind of trial design which the study is currently ongoing, and we have recruited 1 patient in this open label C5 inhibitor related study, and who was randomized to eculizumab arm. So the world has actually moved far away. Eculizumab was kind of brought to clinical use as early as 2007, and currently we have a plethora of complement targeting drugs. I am sure we would talk about this a lot in a few minutes. So just to kind of set the ball rolling, these are the PNH approved treatments: Soliris, eculizumab, Ultomiris, ravulizumab, crovalimab, Piasky, and then we have pegcetacoplan, which is subcutaneous terminal, danacopan, and iptacopan, which have come up. So these almost 1, 2, 3, 4, 5, 6 complement directed therapies which have come. The initial 3 ones are FDA approved, are targeting the terminal complement pathway C5. Pozelimab, as I told, we were a part of this trial. Proximal complement pathway, these are the 3 drugs. Pegcetacoplan, which is targeting C3, while the iptacopan and danicopan, which are targeting the factor B and factor D. And these are actually oral therapies which can be used in adults who are not doing as well on C5 inhibitors. So if we look at what is the future for India, if we look at the prerequisites for optimal management of PNH patient care, we have good laboratory specialists who can very easily diagnose PNH. Most of our labs are equipped with, at least the tertiary center labs are equipped with the flow cytometry services. We have good clinical hematology services. We are kind of super specialists, as these patients can go to GI surgeons or GI specialists, neurology services, and thrombosis care specialists. I think the country has those. We have access to ATG, immunosuppressive therapy, and both in the generic and the innovator forms, including the newer TPO, L-Trombopag and Romiplostim. We have good transfusion services, and we also have an access to hematopoietic stem cell transplant. What is lacking, but however, which is the most important, is the access to complement inhibitors. So we know that while the cytopenia related symptoms can actually be taken care with all the other ATG, cyclosporin, and transplant. However, the hemolysis, the dyspnea, the thrombosis, the organ dysfunction, and the uncontrolled pain, most of these need complement directed therapies. One silver lining is that India, as late as 17th January, the CDSCO did approve eculizumab for atypical HUS and PNH in India. However, the cost needs to be sorted out, and as up till until last year, the cost of this continuous lifelong therapy of Soliris was as approximately around 3.3 crore per year. I would be eager to learn what we have for us now, for our patients now. So with this, I come to the conclusions that the PNH in India, we do have a significant delay from symptom to diagnosis. It was around 30 months in the AIM study, around 13 months in the PGI study. Indian patients with PNH continue to suffer from significant morbidities, which is thrombosis around 1/3 of the patients, transfusion requirements around 60% of the patients, renal impairment in another nearly 1/5 of the patients, and access to complement directed therapy remains a challenge. Thank you.
That was nice, Aryan. Thank you. Thank you for the presentation. So, any questions for Aryan, or we can take up later?
No, I think, very nice. Can I put the first question?
Yeah, please, please, please.
Hi. So, Aryan very nicely, summarized studies both from North India, South India, your own data set from PGI. So, what you highlighted right in the end about, our short of complement therapy, we kind of giving everything to that. So, my question to you is, now with everything in perspective, and we know that the complement therapy is not going to come anytime sooner. Yeah, I mean, because of the cost prohibitiveness. So, what will be your take on reducing the delay in diagnosis? We all know, you also mentioned in your very first slide that it's a progressive disease. The word, I think the most important takeaway is it's a progressive. If we do not treat it, then initially the clone is only going to expand over a period of time. And 30 months in AIM study, 13 months in your study, the time for diagnosis. So the point to ponder, and since you presented the talk and did so much of say, I'll ask your opinion first. How can we reduce this delay from diagnosis so that we can, if nothing else, we can talk about transplants wherever it is feasible?
Yes, sir. Thank you for the question. And I do agree that this symptom to diagnosis interval is an issue which is being recognized in the South Indian study, in our own study, as well as the AIM study. Probably to an extent, it's kind of a lot of time these patients do present to our clinical colleagues from other specialities, and they may kind of not be so much aware. Like two of our patients in our cohort actually from thrombosis, almost it took 2 or 3 months. It was an atypical site thrombosis, and it took two or 3 months to kind of think about PNH and send the test. So I think it's more of education and awareness.
Education, I think, exactly. I think we hematologists have to take a lead to all our general medicine colleagues and including our gynae colleague. A large number of female patients in the gynae department, they keep on taking treatment for anemia, not realizing that they could be some. So LDH, I thought, is a very simple test if we can educate that every patient of anemia where there is a significant anemia, because LDH luckily is a very good marker. Invariably, it will be high. So wherever it's a high LDH anemia, people should start thinking on lines of trying to. I don't expect our general physician colleagues to order a flare or any kind of a flow cytometry upfront, but at least they can start thinking of a hemolytic anemia, intravascular hemolysis with high LDH or something.
True, sir. In fact, that's one test which we often rely whenever we are sending a procoagulant workup in an kind of an unprovoked thrombosis, and if it is an unusual site thrombosis and flow maybe for PNH, even in the government setting, it's kind of costing few thousand rupees. So if the LDH is high, we use it as a surrogate for ruling out PNH, and that can be done in the unexplained iron deficiency anemia situation as well.
Yeah, yeah.
Sure. So what we'll do is, shall we move to the next speaker program?
Just one question, if you have time, 1 minute time. I'm Narendra.
Yeah,
from
Narendra. Please,
RBCI.
please, Narendra. Yeah.
Dr. Arihant actually took a very comprehensive take on PNH Indian scenario. We have trials nowadays and offering anti-complement 5 therapies to our patients, and also offer transplant, even haplotransplant to our patients. But what we have seen in our clinical practice, and also in my own practice and few other patients who came to me from other centers, that they are getting steroids for long term, and they somehow are able to maintain their hemoglobin in a safer range without much complications. And also they may require some anticoagulation. So Dr. Arihant, what would you suggest? So should a patient be treated on low dose steroid along with anticoagulation, folic acid, iron therapies, or should we if transplant is not an option, so what else can we do?
So, sir, short-term steroid at the time of exacerbation is something we resort to just because we don't have the better therapies at our hand. Uh, I kind of did not mention that steroids in our scenario are again not easy drugs. Even low dose steroids, like for one of our patients, did land up in a disseminated tuberculosis rather, with a TBM in these 30 patients, and he was on frequent intermittent doses of steroids. Another patient actually succumbed to a fungal pneumonia. A lot of time they evolve into an aplastic anemia, or they already have a aplastic kind of a picture, which is also there. So steroids have to be used with a lot of caution, and their efficacy is kind of modest, around 20-30%, and sometimes it's just the exacerbation which kind of, once the infection goes, it has kind of gone down. So it's not ideal, but sometimes we may use it. I personally don't use the maintenance dose. I do use a short-term steroid for, say, a week or two, and then I want to get rid of steroids for most of my patients.
Yeah, that's a fairly good idea to use it for short term and taper it off. Thank you very much.
Thank you. Dr. Ayas, can I ask a comment?
Yes, Mukul, please go ahead.
So, Aryan, very nice talk, and you have highlighted most of the points very, very aptly and with too much stress on them. So, My take was on thrombosis. So recently, I happened to have a talk on PNH at a conference, and what we realized that anticoagulation is effective in preventing thrombosis, but not to a large extent. In fact, patients can have a tendency to develop thrombosis at the time of hemolysis while they are on prophylactic anticoagulants, either warfarin or DOACs. And what is your take on antiplatelet prophylaxis? Is it helpful or not?
So, not to my knowledge. In fact, the data on prophylactic anticoagulation again is not very robust. And it's, I think, Dr. Anita from the European group in Hematologica has talked about giving prophylactic anticoagulation. Most of these patients are actually having a venous thrombosis. So antiplatelets again, I don't think would be probably a good idea. The NOACs in a very select group with no risk factors of bleeding uh, is something which I have started using lately for past 2 years with a very high PNH hemolytic clone. But I think it needs more studies to kind of validate that.
So earlier we were using aspirin a lot more, maybe last around 7 8 years, but over last 2 3 years we have trying to shift to rivaroxaban or apixaban prophylactic doses for many of these patients. Thank you.
Thank you.
Thanks, Aryan. Thanks very much. Thank you, panelists. So I like to invite our guest speaker to evening, and I welcome Dr. Austin. He's a hematologist in King College Hospital, London. He's been there in reviewing mainly the PNH and the leukemias. So welcome, Austin. So this is a rare topic. I will really love to hear from you. So over to you.
Okay, thank you so much, Rez, for that kind introduction, and thanks, Arihant, for that fantastic talk as well. I will try to. I've got hundreds of slides, so I'm not going to keep you here forever, but I'll try to talk just a few things around PNH and applicability, and I'll touch upon a bit around transplant as well, and also the expanding anti-complement therapy. I will skip over things which Arihant has covered or which are too something which might not be relevant yet to Indian practice. We keep saying that, yet I'm still hopeful that access to anti-complement therapy will become easier and the prices will go down as well. Yeah. So some of my disclosures predominantly. So I always start with the case because I think Arihant has nicely shown, is it? Because I think it's important to differentiate a hemolytic classical PNH with aplastic anemia with a large PNH clone. Yeah, because when we looked at our aplastic anemia database of 640 patients, 40% of patients had a large had a PNH clone, and 20% had a very large PNH clone. So they would not have a red cell clone. So they don't have the hemolytic capacity ability type of thing. So this is she's still with us, very transfusion dependent aplastic anemia, and we were still using steroids and oxymethylone. This was even before the days of ATG cyclosporin. She had an improvement in the blood count. So thankfully, we don't use HAMS test. We use flow cytometry. But she used to get intermittent episodes of transfusion or every 6 weekly, but never had a thrombosis. And that's again something which came out, is it? Because we don't know. I think from data, looking at what Arihant presented and looking at other Asian data, I think on an average, maybe 10 to 40% of patients with PNH get thrombosis. Yeah. But why does the rest of the 60% don't get thrombosis? We don't know. Because we have patients who have 95% clone who don't get thrombosis, although they get hemolysis. So those are things which we've not worked out. And she used to get very much dark urine, and we know PNH is a fascinating disease which has got thrombosis, hemolysis, and cytopenia. If you understand complement and PNH, you probably understand the whole medicine, I think so, because it's a fascinating area. And we know it is due to a somatic mutation in the PIGA gene, which causes all the hemopoietic cells, i.e. the progeny of the cells. And you probably know historically we used to do clones in the lymphocytes, not on the red cells or other types of white cells. So it is a clonal stem cell disorder. And we know it is because, so we don't look for the PIGA gene, we don't look for the GPI anchor, we look for the complement regulatory proteins on the surface of the cell, and that is what we know as PNH. And as Arians has shown, that we know red cells are millions and trillions, and these red cells are protected by complement regulators. But when you get PNH, when you get complement activation, we're all sitting here or sitting wherever you're sitting, but we know complement system is always active because it's the first line of defense, innate immune system that causes hemolysis. And this is going back to basics, but we know complement forms the part of the part of your innate humoral immune system where the complement sits, but we know it's not in boxes because we know there is an interaction between all types of the immune system as well. I think I'll skip that. Yeah, and complement, as we know, is classical lectin, an alternate pathway which leads on to membrane attack complex, but the proximal pathways like opsonization, phagocytosis, chemotaxis is critically important before the target cell lysis happens with the effect on the complement system. And we know, as somebody has already said, we all know that it's fantastic that the diagnosis of PNH is very much, flow cytometry is very much available in India for a number of centers and number of hematologists as well. So that's great. And somebody already mentioned, is it, that you never have a ultra rare disease or an ultra orphan disease which has got such a sensitive diagnostic test and such a sensitive monitoring test in the form of LDH. We can never go wrong. And I think quite somebody did stress that as well, is that we need to encourage other physicians and other people to do the LDH. And we know LDH, retic count, and all those things, we do it as hematologists, but not everybody does it. But it could be something which we can use to pick up these disease, because we know nature has kept the hemoglobin to be protected within the red cells, not to be released. And we know free hemoglobin is a good mopper of nitric oxide as well. And I don't know, I know we talked about steroids and other things, but there has been, people do use PDE5 inhibitors, like sildenafil, Viagra type of drugs, because that can help to replete some of the nitric oxide, like used for people who do have significant erectile dysfunction and even dysphagia as well. Who do benefit, because it's the same pathophysiological mechanism, is it, that you can have. And we know it's a disease of progressive. And here I just want to touch upon, because there was a question about antiplatelet agents. Mechanistically, I do not think antiplatelet agents will have any role in the context of PNH, both in the prevention of thrombosis, because which is one of the reasons we say anticoagulations will also not have a significant effect, although we still use it, which we'll come to in a second, because here you're talking about the complement system, not about other aspects of the coagulation cascade and other things. And we know that these patients get number of these symptoms which you have. And I think thrombosis is interesting, is it? Because as I told you, the highest is seen in around 40%, and Arihant showed that could be between 10 to 20% in the Indian population as well. And some of the graphs which were shown, actually, we know the median survival is quite short in the context of untreated PNH as well. Although, again, this is where the definition comes in, because historically, quite a lot of patients who had aplastic anemia with a moderate or a subclinical PNH without hemolysis might have been classified in this category, that they had treatment options, including ATG, cyclosporin, and transplantation as well. But thrombosis varies between patients to patients and different cohorts as well. with symptoms, which we talked about as well. I just want to give you this data where we looked at all our patients who were treated with anti-complement therapy, 509 patients, but not to talk about anti-complement therapy, but mainly to talk about how these patients were picked up and presented. So this is over 20 years. We had treated 509 patients with either eculizumab or ravulizumab. This data was published in Blood, I think, early part of last year. And if you look at it, the median age, again, there was not much predilection between male or female, and you can see the clone size as well. So this is where median granulocyte clone. And history of aplastic anemia, you can see 42% MDS. And thrombosis in this recent data set is 26.5%. So I think it's a variable incidence, but it's between 10 to 40%. So it is quite and how the patients present as well. And the median time, you might think like one of the people mentioned, like early diagnosis is always important, and it's important to keep educating other specialities and other people as well. But we still, even in UK, we do still see patients misdiagnosed, late diagnosed, presenting it to different specialty, and the commonest being gastroenterology and urology. Iron supplementation and iron infusion is not the cure for everything, and not all dark urine is hemoglobinuria. It's not hematuria. I know hematuria is more commoner than hemoglobinuria, but we know these patients. I had a patient who was with the urologist for 6 months with 3 cystoscopies, multiple CT KUBs, and this was all hematuria rather than hemoglobinuria in that. So still these diagnoses takes ages as well. And we keep showing this slide because as hematologists, we know in the context of MDS, AA, and unexplained MDS and AA, we should do it. But it's also in unexplained cytopenia. We've been caught out as well. They might have subtle cytopenia with a non-diagnostic bone marrow, but then when you do an LDH or a retic count, they're high. So some of the key markers as well. And unprovoked and unusual thrombosis. And here, this is where I talk to people and say, like, if you have an availability of a PNH testing, why don't you just do it? Why do you want to think of whether could it be PNH, could it not be PNH? So if you've got a possibility of doing it, just get the test done so that we can make sure that it is negative in the right context as well. I think Arihan touched upon it as well. We do see arterial thrombosis. This is the South Korean data, but I would say 20 to 30% of patients do have arterial thrombosis as well. I recently saw a chap with a coronary artery occlusion with the pristine coronaries without any atherosclerosis and any type of thrombosis. Dermal vein thrombosis, that's also quite not an uncommon entity as well. I don't know whether you guys still use the other prothrombin, protein S, protein C. We've stopped doing it because we know the risk of getting VTE is about 2 to 5-fold. But if you have a PNH, the risk of getting a VTE is about 62-fold. So it's important, even if you pick up one patient. So what happened to our patient? Yeah, so she was one of the first patients to go into the clinical trial with eculizumab, which I'll come to in a second. But we all know 40 to 60% of patients with aplastic anemia will develop with expansion of the PNH clone, because this is because of the persistent immune pressure in this and leading to expansion of PNH hemopoiesis. Which is why whenever we look at the data, you need to be careful about, is it really hemolytic PNH? Or is it aplastic anemia with a subclinical small or a moderate PNH clone without hemolysis? And it's also important because I always show this slide, but I haven't got it. Whenever you have expansion of the PNH clone in the context of aplastic anemia, there is sometimes a likelihood that these patients could respond from their aplastic anemia. So that could be sometimes misinterpreted as the patient is responded, but there is an acquisition of PNH clone as well. So this was a long term back when we published this data, but I won't expand on it. But essentially to say that PNH clones are part of either normal hemopoiesis, they can be part of MDS clone or other clones as well. So this is a dynamic disease, yeah? So you can sometimes be aplastic anemia, it can go to AAPNH, you can cure your aplastic anemia and you can get to hemolytic PNH. Going from PNH to aplastic anemia is not that common, but we do see cases in this setting as well. So I think when you look for these unexplained cytopenia and testing, you will pick it up. And I already touched upon it. And most of the time, this PNH clone could be subclinical, but in about 1/5 of the patient, the PNH clone could be high as well. Yeah. And again, post IST, it's not that IST is increasing the PNH clone. It's just that the recovery of the normal hemopoiesis can potentially lead on to expansion of the PNH clone. So this is one of the BCSH guidelines where we say if you have an aplastic anemia, if they continue to be negative, still repeat it. But if they're positive, repeat every 3 monthly. But if they're stable, every 6 monthly as well, so that we can monitor it. So this data was published in Leukemia, where we looked at, because we had the habit in King's that every patient who comes in with MDS will also have a PNH clone as well. So we utilized this, and we were surprised to find that even in MDS, 20% of patients had a PNH clone, and in aplastic anemia, around 60%. And the correlation, which I think Arihan touched upon, the higher the PNH clone is, there is greater risk of thrombosis as well. Yeah, and it also had an impact on the survival. I think I'll skip these ones. Yeah. And some of these thromboses, I still vividly remember this patient who is a long time back, but had recurrent episodes of thrombosis and had a dense cerebrovascular accident with an expansion of the stroke as well, with a large clone. But he's one of these very, very rare patients. I don't want you to get confused, but there are very occasional patients who have large granulocytes and monocyte clone, but don't have red cell clone. So they don't have hemolysis as the reason for their thrombosis. And I'm not a thrombosis expert, but just essentially to say there are other causes of thrombosis not related to as such to hemolysis, but nearly 90 to 95% of patients who develop thrombosis with PNH is because of their hemolysis as well. And sometimes the predictor of these things, and I don't know, we talked about it, we still use primary prophylaxis, and we've switched from warfarin to DOACs. Predominantly, we use apixaban, but occasionally rivaroxaban. In people who have a large clone, who have sufficient and safe platelet, and who do not have contraindication, we do sometimes use anticoagulation as a primary prophylaxis in this setting as well. Yeah, and we sometimes get these patients who do have who sometimes are referred, they are pretty well, but they're coming in for opinion. And when we do an ultrasound, they do have Budd-Chiari with the LDH being 3040, normal range being 240. So this was a case who had Budd-Chiari. She was referred because she had a reasonably stable blood count, but high LDH. And when we looked at her Doppler ultrasound, she had already formed a Budd-Chiari. She's had anti-complement therapy, and unfortunately, she had to had a liver transplant because of her Budd-Chiari as well, because she got significant portal hypertension and bleeding as well. Yeah. And again, subclinical thrombosis can be identified as well. I don't know whether you use thrombolytics, but in PNH, we don't use it because in the context of anti-complement therapy, we don't use it as well. And sometimes these patients get thrombosis, which can be quite extensive as well. They come in with hemolysis, and then they get thrombosis, and then it gets extended over a period of patient. This patient had clotted off right from the top of the neck to the infrarenal IVC within a period of 10 days as well, due to her PNH and thrombosis as well. So, and this again was alluded to, if you get a first thrombosis, there is a 50% risk these patients will get a second thrombosis unless they are treated with This is where I think secondary prophylaxis doesn't work. Yeah. If you develop a thrombosis and you have active PNH, I know we will always put them on secondary prophylaxis, but if they have quite active and complement activation and hemolysis, unfortunately, the anticoagulation does not prevent the recurrence of a second thrombosis. But you do have patients who are on primary prophylaxis who never get a clot. But the question is, even if you didn't give them primary prophylaxis, will they have never got a clot as well? Yeah. So diagnosis, we touched upon it as well. So some of the things which we use as hematologists, like the retic count and LDH, could be quite useful in this setting as well. I think Arihan touched upon the classification of the PNH as well. Yeah. I think I'll skip that because we've talked about the flow cytometry in this context as well. Yeah. So I know we have talked about other treatments, and there was so much discussions around whether you would use steroids, androgens, anabolic steroids, anticoagulation, and this is how it was in countries where they have access to anticomplement therapy. This is a very, very old data, nearly 20 years back, and this was where giving primary prophylaxis was started because of the granulocyte clone. So if you have a more than 50% granulocyte clone, the incidence of thrombosis is close to 50%. But if you give them primary prophylaxis, the incidence was significantly reduced. While if you did not give them primary prophylaxis at that time, warfarin, this was very high as well. And again, I talked to you, even if you anticoagulate, patients do have a high risk of thrombosis once they've developed a thrombosis if you do not treat them with anticoagulation. And this is where the clone size and its relationship to thrombosis comes in. So if you have a higher clone size, there is a 40% increased risk of thrombosis as well. We talked about it. Okay, now touching a bit upon transplant, and then we can have a discussion as well. So what do you do in countries where you do not have anticomplement therapy? And this was what was the historical data. This is in 2010 and in 2012. You did have a higher transplant-related mortality of around 40% with an overall survival of 60%. Tiny bit got better, but still the risk of chronic and acute GVHD was extremely high. And this is where the French group and the EBMT looked at it. And this is looking at patients with classical PNH. And this is similar to the graph Arihan showed, patients who had thrombosis, yeah, with classical PNH and had hemolysis, while patients who had AA PNH, or what they defined as intermediate PNH, where they defined it not fitting into any of the criteria. If you have AA PNH, they're anemic, thrombocytopenic, and have neutrophils less than 1. So those cohort of patients who had thrombosis, unfortunately, after transplantation, had a very poor outcome. While when you look at those patients who had isolated hemolysis and you did not have anticomplement therapy, these patients had a better response to treatment in this setting as well. So the biggest problem with transplantation in hemolytic PNH is related. So the outcomes are getting better and better, and I'll show you some of the recent EBMT data which was collected looking at transplant outcomes, which was presented in ASH as well last year. But the risk of GVHD and infections is the problem. The reason is with anticomplement therapy nowadays, I know there is significantly restricted access or no access in India. But when we used anticomplement therapy, we were able to change the survival prospects of this group of patients with eculizumab patients with PNH, when you know the mortality was extremely high, and this has been altered. So they wanted to look at the matched pair analysis. And even if you did a transplant for the ones who had thrombosis, unfortunately, they had a significant poor survival, even compared to patients who did not have anticomplement therapy, who did not go into transplantation. So that's the bottom line of transplantation. Yes, it can be used, but unfortunately, it also has got issues related to GVHD, transplant-related mortality as well. So some of the treatments which I'll cover hopefully in the next 5-10 minutes or so is around, I think we all know, we won't be sitting here unless we know why patients need treatment, who needs treatment, and when do they need treatment. But we're talking about availability of C5 inhibitor transplant and other nitty-gritty as well. So this same patient went on to get treated with eculizumab. She was one of the first patients in 2002. So she's still with us 23 years on treatment, initially with eculizumab. As it's shown here, she had a reduction in her LDH. Her PNH clone expanded as well because you stopped the hemolysis, and her urine got better as well. And we know that because eculizumab was never made for PNH, but it was a serendipitous discovery that it binds with high affinity, blocks the terminal pathway, and the proximal functions are intact. And it sort of helped a remarkable turnaround for this group of patients because LDH went down very much. compared to placebo. And if you look at the other trials, and if the same patients were not on placebo, what would have happened to their LDH is shown there as well. So again, eculizumab has sort of significantly changed the outcome of this group of patients. And you can see pre-treatment, the number of thrombosis, and post-treatment, the number of thrombosis as well. So it's not that it totally abolishes, but it significantly reduces. And sometimes we look for other causes of thrombosis on eculizumab as well. And that's what. So significant reduction in thrombosis. And if you look at it efficacy-wise, it's been shown. I think accessibility and cost is the big issue, but effectiveness of this anti-complement therapy has been extremely good as well. So we tend to treat patients if they're transfusion dependent due to PNH, if they're independent of transfusion, if they have a thrombosis, if they have complications or have hemolysis or exceptional circumstances. And this is what the EMEA, European Agency, says. You have a high LDH and one of those symptoms as well. So till date, we have, so for people who don't know how the PNH service is organized in UK, so I lead the PNH service at King's, and it's in Leeds, it's led by Mara Griffin and Richard Kelly. So we started the service back in 2009. So currently we have 1,121 patients as of last year. And as you could see, not every patient with PNH need treatment. So nearly 670 patients are not on treatment, and so only 675 patients were ever treated. So essentially saying that these patients can be monitored, but only patients who don't have significant hemolysis or a subclinical clone, or they have AAPNH. And that's why the survival of this group of patients are remarkably changed over the period of years as well. So I think the main thing is, like, if you have a classical PNH, we will always treat with a C5 inhibitor. There is no need for treatment for a subclinical PNH. Even PNH with aplastic anemia and MDS, you only treat if there is a large clone, if there is evidence of hemolysis, if there is any other complications. So what did she do? She changed over to ravulizumab when the study began, because the ravulizumab is the modified version of eculizumab, which is given 8 weekly, and she's on the treatment for the last 7 years as well. And ravulizumab does the same thing, that it improves the survival. And it's given every 8 weekly. And vaccination is important for this group of patients because of the blockage of terminal complement activity. So PNH is sort of definitely a disease of intravascular hemolysis, as you've seen in this context, that C5 inhibitors work in this context. And I showed you already that how these ravulizumab. So, but if you look at it, patients sometimes do remain anemic on eculizumab or ravulizumab or C5 inhibitors, or the ones which Arihan showed with tocilizumab and cemdisiran as well. And this is because of this phenomenon now we start recognizing. So you got a patient, PNH, we know it's intravascular hemolysis, that is negative. But once you start these patients with eculizumab or ravulizumab or the recently approved crovalimab in Europe, these patients do get proximal activation, and they get C3d deposition on the surface of the red cells. And we know that it's CD55 and 59 deficiency, but there is activation of the proximal pathway, which can be picked up by flow, and they have to be taken up by the reticuloendothelial system and be taken up by the liver, spleen, by the macrophages and the receptors in there as well, causing extravascular hemolysis. So which is one of the reasons that newer anti-complement therapies have come about, that these patients need to be monitored and managed for their extravascular hemolysis. And that's where iptacopan, pegcetacoplan, and danicopan has come about, to see whether those agents will prevent the onset of extravascular hemolysis. So this is a drug which is given subcutaneously twice weekly, and it shows that the hemoglobin levels have gone significantly up when these patients were on eculizumab and switched over as well. Similarly, iptacopan, which we published recently in NEJM, it's an oral compound given every twice a day as a monotherapy. And as you could see, these patients, when they switched from eculizumab or ravulizumab, their hemoglobin significantly improved. What about danicopan, which is a factor D inhibitor, which is used as an add-on to the C5 inhibitor? So we've been using the danicopan trial for many, many years, phase 1, phase 2, and phase 3. As an add-on to eculizumab, when you added it on, you see that the hemoglobin starts to go down, the retic sound goes to go down as well. Or you're adding cost to that underlying treatment? Probably yes, but it seems to have a benefit to this group of patients. So as a service, these are our patients who are on ravulizumab, eculizumab, or other treatments and clinical trials as well. I think we are trying to see what is an ideal complement inhibitor. While I know, understandably, in countries who do not have access, they're looking to see what can they get any complement inhibitor, which could be cost effective for patients and be able to improve the quality of life. So this is how complement inhibitor therapy has gone over these last many years. Since eculizumab and ravulizumab, now we have number of agents, at least in Europe and US, and countries where these are approved. And essentially to say that there are a number of agents. I know Arihant mentioned about the other complement inhibitors, the cemdisiran and the tocilizumab here, but there are other proximal inhibitors, there is lectin pathway inhibitors, there are MAS3 inhibitors, there are biosimilars, and that's an important thing for countries which do not have access, because there are at least 2 approved biosimilars in US and UK, and could any of these biosimilars be accessed? And we're still doing trials of other agents as well. And I think we might come to a time, at least here, where we might have more drugs than patients to treat this rare group of disease. So just a last slide, but I've got a couple of slides on transplant. I don't know, Dr. Riaz Ahmed, whether we have time to talk a bit about transplant, or should I stop there and take questions and use it during discussion?
No, please continue. It's a very nice presentation. Please.
Okay, I'm going through I'm not going in a marathon pace. I'm going at 100 meters pace. So essentially, just to thank all the people here, and then I'll come to transplant in a minute. And we did just trials. That's what we did with these agents. And just by trials, we've saved about 72 million in this. So the question is transplant still an option for these patients? And I would say still yes, because, in country, it's only about 40%, 40 countries in the world who have access to anti-complement therapy, which are reimbursed and taken up by the government system. Yeah, because transplantation was one of the first therapies used in this context for PNH, and this is from Rainer Staub from Seattle. So I'm just using as a case an example. We got this patient who's 21. Now he's about 26, 27 now. He had an LDH of 2,241, anemic, symptomatic. Fantastic. He had a twin brother, monozygotic twin. What else can you expect for a non-malignant disease? So question is, would you transplant or would you give anti-complement therapy? At that time, transplant outcomes were poor, but not for a syngeneic transplant. And the data was very patchy. But this patient never wanted any treatment. It took us 6 years to convince him to go on eculizumab and then to ravulizumab. And he's doing very, very well. But question is, he's accumulated costs this much every year, and he was 21, we started at 27. He could live for 70, 80 years, and you're sort of accumulating 3 million every year in the cost, is it? So the question is, could transplant have been used? Because we know in the context of aplastic anemia, transplant outcomes are getting better and better. We use the regimen of flu cyclophosphamide and alemtuzumab with very, very good outcomes as well. So it's quite tempting to think of transplant in this setting. But the biggest problem is transplant-related mortality, about 40%, as I showed before, and 5-year survival of 68 to 70%, and also the GVHD risk. I think we touched upon it, so I'll skip that. Yeah. So if you do not have anti-complement therapy, how would you transplant this group of patients? So this is from the French data looking at T-replete transplant. So these patients indications for transplant were PNH with bone marrow failure, 3 had thrombosis as well. And when all of them engrafted with a full donor chimerism, with the risk of grade 2 to 4 GVHD was around 47% as well, with a median follow-up. So there are a number of data with using transplantation in PNH when you do not have access to anti-complement therapy as well. Because we always say that in the context of aplastic anemia, where you think of transplantation in the right context, but in the context of PNH, we always talk about anti-complement therapy. But if you do not have access to anti-complement therapy, transplantation should be considered if you have the right donor and counseling and all those things as well. And definitely aplastic anemia with hemolysis, this group of patients you should consider for transplant. So we published a few data using anti-complement therapy with transplantation, which is not applicable, and we are going to expand this data as well. So what about, so this is the French data where they used eculizumab and then transplanted this group of patients because they progressed to aplastic anemia, and this is their overall survival. So even in patients who have had used eculizumab, these are not very easy transplants to do, but they had GVHD and other complications as well. And there has been few data published. So we are putting together our data of around 60 to 70 patients who had eculizumab, ravulizumab, or other anti-complement therapy and went in for transplant. Some of the initial data I presented it a few years back. But even in this group of patients, which I'll skip through, there is an increased risk of complications, because this is what the overall survival looks at in this 18 patients who had PNH, had eculizumab or ravulizumab, and then they progressed to aplastic anemia, and some of the complications were related to infections, graft failure, but also we know occlusive disease as well. So there is a possibility of doing transplantation in this setting as well, but the complications needs to be looked at in this in this context. So if you do not have access to anti-complement therapy, will you consider a transplant? I would say yes. Obviously, caution in the cases with thrombotic PNH, GVHD risk exists as well. If you can access short period of anti-complement therapy prior to transplant to control their hemolysis and complications, you should do that as well if it's possible. But if you have complement inhibition, would you consider transplant? I would say no. For a hemolytic PNH, yes. For an AA PNH, you can consider, but there are patients who have suboptimal response, but we have number of newer agents as well. But yes, in the context of concurrent bone marrow failure and coexisting AA as well. So, or relapse of AA or progression to obviously to MDS and AML as well. So I think I will stop there, and happy to, and there is always a temptation, is it, in a 20-year-old with a sibling or a syngeneic donor, when you think the cost of anti-complement therapy over many, many years, there is a rationale there as well. I probably wouldn't present the next data. This was for people who want to look at it, the updated data of the EBMT aplastic anemia working group, where we looked at PNH and their outcomes after transplantation was presented, but happy to talk about it. But the long and short is the outcome seems to be better in this group of patients who had transplantation in this 2011 to 2020 as well. I think I'll stop there, stop sharing, and happy to take questions. Hopefully, although it was quite a lot, hopefully I was able to cover everything what you wanted to hear, and happy to take questions. Thank you.
Thank you very much, Austin. It was great. So, any questions from the house?
Yeah, Riaz, if I am allowed to
Yeah, please,
ask the
please,
first.
please.
So, an excellent exposition. Austin went through like a 100-meter dash, but everything was so succinct and clear. So I'm sure if I'm not aware if other members on this August panel which are here, how many of them have used eculizumab. My answer is zero. I have not used eculizumab, or didn't have the chance to use any eculizumab on any of my PNH patients. So still I will be interested in asking you, because I saw from your data that in your King's College cohort itself, you had a certain set of people in which, despite having classical PNH, you said not everybody is on treatment, and more importantly, people who had started on anti-complement therapy, you've stopped them. So
Yeah.
my question is, what are your stopping criteria? So you very clearly said what are your starting criteria. So there's no confusion about when would you start anti-complement therapy, but in which patients would you stop therapy? And secondly, over a long term period, I'm sure you've got guys who have been on more than 10 years on anti-complement therapy. What problems are they facing on a long-term anti-complement?
Okay. Yeah. I think there are three questions. I'll take it backwards. Yeah. Very, very safe anti-complement therapy. Patients get it at home. Yeah, because it's a monoclonal antibody, but it's not like a rituximab or any other reactions are very, very short. Patients get it at home, and even with ravulizumab, they get it at home. One definite complication is because of the terminal pathway blockage, they will get risk of meningococcal meningitis. They don't manifest as meningitis, they manifest as sepsis, which is why we get vaccination, they get prophylaxis with penicillin, because most of it is nasopharyngeal carriage as well. We've seen 11 meningococcal meningitis in 10 patients over the last 22 years since we started eculizumab. Yeah. One of them was fatal because he presented very late to the hospital. Rest of them were rescued. No other infectious or malignancy or autoimmune disease or other complications. Yeah. So that's the first question. The second question going backwards is, when do you stop treatment? So we've got 11 patients who had gone into a clonal remission or a regression where we stopped the treatment. We've also got about 20 females who we only started for pregnancy to prevent the complication. Postpartum, once they're stable, we've stopped it. And we've got a group of around 70 patients whose PNH evolved to bone marrow failure, either aplastic anemia, either MDS, or even to acute myeloid leukemia. Those patients, prior to transplant, they had stopped it, and then they went into transplant and transplant conditioning as well. So those are essentially the indications for transplant. Why do I not start some patients who have PNH on anti-complement therapy despite availability of 6 or 7 approved agents in UK? That's because it's a clinical spectrum, and we do have patients who have a large PNH clone, but their hemolysis is very well compensated. They've not had a thrombosis. They have a good quality of life. We put them on primary prophylaxis still. The French don't do it. We still do it. And we've switched over to non-warfarin Dovax and Novax as well. So we don't treat all those. We carefully monitor them. If they start getting symptoms, or if they have clone expanding, or the LDH goes up, then we start them on treatment. So for me, not all patients would need treatment, because there was a time in US when people started treatment with 1% PNH clone. Just because you've got a drug doesn't mean you have to use it. Yeah, and it's the right clinical context. I think I would use it.
Can I intervene? I'm Narendra. Yeah. So my questions, when to stop anticoagulation in a patient who was on therapeutic anticoagulation and now started on anti-complement therapy, or received a allotransplant and is in remission, post allotransplant in molecular remission, and post anti-complement therapy in remission. So when to stop anticoagulation in such patients?
Yeah, I think that's fairly easy, because you got rid of the disease essentially, is it? Because they've gone into a clonal remission, either due to transplant or normally. We have stopped secondary prophylaxis in this. For patients who are on primary prophylaxis, who've gone to get anti-complement therapy, we tend to stop it after 2 to 3 months, because their LDH starts to go down very quickly. They're very stable, and we get rid of them. And even for the 10, 11 patients we are looking at who had a clonal remission, 2 or 3 patients had extensive thrombosis. You know, the lady I showed you who had a thrombosis right from the top of the neck to the bottom of the kidneys, she's gone into a clonal remission, and we've stopped her anticoagulation because the primary drive is gone, technically. Yeah. So
yeah, and so one point which I beg to differ is that higher mortality in PNH transplants, though historically it has been higher, but nowadays I think with advent of newer conditioning regimes, the mortality is coming down steeply. And now it's a bit more safer as compared to the historical data.
Yeah, no, 100% agree. And I think it is a question of, but the problem is in a country like UK where you have access to anti-complement therapy, when you take them to a transplant, you cannot not even quote a 10% mortality, and you have to quote a 10% mortality and a 10% risk of GVHD. Yeah.
Yeah.
Compared to an anti-complement therapy, which will keep them going. Yeah. But 100% agree, Narendra, that in countries where they don't have access, it's a balance. Yeah, risk balance benefit, and say, yeah, I'm happy to take that mortality risk. Yeah. So, but you're right. Things are getting better from the transplant perspective. And within inverted commas, it's a curative approach rather than a lifelong treatment. So, and I am a transplanter as well, so I'm pro for it. But similar to you guys, restricted not having anti-complement therapy, mine is restricted because when I have access to so many anti-complement therapies, I need to have a very, very strong rationale to take somebody to a transplant.
Yeah.
Austin,
Thanks.
if I may ask a question.
Yeah.
Yeah, I'm Dr. Rajan Kapoor. Excellent talk. So just probably we'll discuss about transplant later on also. You said that the conditioning, you're moving to a RIC rather than MAC, because whatever hemolytic we did, we have done a MAC conditioning. So what's your take on
Yeah, so
versus MAC?
I definitely don't think these patients need a myeloablative. Yeah.
Okay.
The question is how non-myeloablative can you go? So we used, okay, I'll explain to you in two different ways. When we looked at our aplastic data with FCC conditioning transplant, which is the gentlest transplant you can get, flow cyclophosphamide, Campeth, 40% of patients or 30% of patients had a granulocyte clone of median of 60%. Yeah. Even with that FCC, the PNH clone disappeared. Yeah.
Right.
So for very cellular marrows with hemolytic PNH with a large clone, we are now using flu-bu, but the bu is a very, very small dose of bu, B2 type of regimen rather than a B4. Some people are using trio as well. So I don't think so you need a proper myeloablative.
Right.
Something very gentle like an FB2 might be sufficient. And I think in India, you might use an ATG while
No.
we use
Oh,
Campeth. Haplo, technically, the Baltimore approach could be sufficient, but I've not seen significant data for hemolytic PNH using the Hopkins Baltimore with post-transplant side, but that should be sufficient.
yeah, I guess so. We probably will discuss that because we are also going now doing haplos for PNS more and more. I think Narendra has also done it. Thanks.
Good evening, Dr. Austin. If I may ask you a couple of questions.
Sure.
Yeah. So is there an absolute percentage of a clone in which you label it as a hemolytic PNH vis-a-vis and, aplastic PNH overlap?
No,
Like somebody with a 92%, 93, 99% clone. I had a patient with a 99% clone.
Yeah.
He had a hypocellular marrow. He had cytopenias. And he was coming like every month to the hospital with, I think, esophageal spasm, mimicking a myocardial infarction. And he also had chronic Budd-Chiari.
Yeah.
So
I think again, Amrita, it's the context is the main thing, is it? Like that patient clearly has a hemolytic PNH. And if you look at the red cell clone in that, they might have 40-50% at least, because the rest is hemolyzed and other things. Yeah. But in aplastic anemia, what we see is they get a 90% granulocyte and monocyte clone. But when you look at the red cell clone, they're 2%, 1%. It's not because of hemolysis. It's not because of transfusions. It's just that they don't have that much. They don't have hemolysis as such. Yeah. So I will answer your first question in a different way. So we've got number of patients who have a 90% clone who have compensated hemolysis, like I was answering to your colleague earlier on, who we don't treat. Do I have any patients who are less than 10% who are on anti-complement therapy? No, as well. So clone size matters, but it's mainly the clinical symptoms, hemolysis. If they have spasm, thrombosis, then they should be, if you access-wise, if you do, they should be treated as a hemolytic PNH. So there is no absolute cutoff.
So my second question is, let's say we have an aplastic anemia with a large clone, 80% clone. Would you be cautious about using L-thrombopag in those patients?
No. No, we presented the update from the RACE clinical trial data of using ATG cyclosporin L-Trombopac. You'd be surprised that there was more hemolytic PNH in the non-L-Trombopac arm. Yeah. So it seems to be a reflection of improvement in the hemopoiesis rather than due to expansion of the PNH hemopoiesis in that context. So at the moment, there is no data available to say that L-Trombopac per se will increase the risk of PNH clonal hemopoiesis. It seems to be paradoxically the other way around, that there seems to be more recovery of normal hemopoiesis in patients with on the triple therapy, that the risk of PNH clone seems to be lower. Obviously, it needs to be ascertained. Yeah. One thing I'll do for those patients is I'll closely monitor their hemolytic markers, make sure you repeat their PNH clone every 6 to 8 weekly so that you don't miss if they develop hemolytic PNH with thrombotic potential.
Sure.
Thank you.
Just one question, Dr. Austin. What's your advice to, this is in the chat box, what is your advice to young female PNH patients on no ongoing hemolysis if she wants to plan a pregnancy? This is by Dr. Sanjeev, one of my friends from PJ Lucknow.
It's a tricky one, is it? Yeah. So historically, women were discouraged from becoming pregnant because unfortunately the maternal mortality rate was close to 20% and the fetal mortality rate was around 10 to 20% as well. So at least in countries who do have access to anti-complement therapy, we actively encourage women to say, if you want to get pregnant, we will support you because it's a finite period. I think it's very tricky in country where you do not have access to anti-complement therapy. I think, like Arihant was saying, if they get acute hemolysis, managing them with steroids, managing them with other agents, supporting them would be important, but it's so difficult because you cannot. We've not lost a pregnant female or a baby in the last 15 years since we've been using anti-complement therapy. We had multiple pregnancy, twin pregnancy, triplet pregnancy even. But in your practice where you cannot access anti-complement therapy, is it going to be tricky? It's a high-risk pregnancy. Yeah. And I've always, whenever I've said this, they say, if a woman want to become pregnant, they will become pregnant, whatever you say. You can't stop it, but you need to support it. I think transfusions is very good, supporting them with intermittent steroids. If they have a marrow failure component, using cyclosporin would be useful as well. Thankfully, it's a finite period. Hopefully, you can tide over. Postpartum is risky. We still, despite using anti-complement therapy in pregnancy and postpartum, we use therapeutic doses of anticoagulation as well, low molecular weight heparin. Yeah, so that needs to be supported along with the pregnancy as well. Yeah. But I can't confidently say yeah, they can become pregnant.
Thanks, Dr. Austin. So with this, please stay around, Dr. Austin. So the last part of this session is by Dr. Sanjeev Sharma. So he will be presenting a case and we can join in to have the questions on that. Over to you, Dr. Sanjeev.
Yeah, I'll just see if Arint, you had a question to Dr. Austin. I think we can just start off with that because just before the thing started.
So, in continuation with the safety of L-Trombopac, I think a lot of us are actually using a lot of androgens again. Do you think they actually work in say one in the non? First of all, I feel whether do they actually work in the aplastic cohorts as well, and particularly in the non-aplastic cohorts one, and if we have a aplastic one with a higher PNH clone with an hemolytic component, do you think androgens would be more detrimental as they cause dyslipidemia, liver problems, and probably higher risk of thrombosis as well?
Yeah, difficult one, is it, Ari? And you probably have more experience than me in using androgens in the context of marrow failure and PNH. I use a lot of androgens in aplastic anemia, immune mediated, older people who who have not responded to cyclosporin L thrombopag, who can't tolerate ATG and content. In our hands, about 20 to 30% response of using danazol. We use mainly danazol, occasionally oxymethylone, 20 to 30% response. But I've not gone in to see whether they had a preferential response in those who had a PNH clone versus non-PNH clone. So we also published our androgen data from EBMT in Hematologica a year back, I think so, but that was a bit of a hodgepodge of different data. But I don't know. Yeah, I don't have enough experience on that context to give you an answer. Yeah, but you probably have some idea, is it?
I feel they don't work, they cause more problems. So that's why I thought I'll just ask. Thank you.
Sure. Okay. So I think as a last part of the presentation, I think most of it has pretty much been covered in Arihan's and Austin's talk. So, just in 5 minutes, try and wrap up a little one transplant case, which in PNH. So, a disclaimer is that I am only presenting this case. The transplant has been done by Dr. Rajan Kapoor, and the slides and the entire presentation has been made by Dr. Rajan Kapoor, who is also there in the panel today. So, so this is a young girl, 12 years, in 2021. She came to me in Lucknow, and she had cytopenias. She used to come actually to the gynecologist for a menarche menorrhagia, and the gynecologists were happy giving her blood and iron infusion till one day they said that why then they got sick of her. Why don't you go to the hematologist with an HP of 5? And what I found was that actually it was not just hemoglobin. She had cytopenias in all three cell lines. The retics were low, the LDH was high, and she did give a history of occasional abdominal pain. DCT, ICT was all negative, no schistocytes, hemosiderin was positive. So straight away we got a flare, and it showed a PNH clone size of 10%. Marrow was done. It was a hypercellular marrow with multilineage dysplasia. So it was a clear-cut MDS with a overlap of PNH. Now, initially, we started her on supportive therapy, the EPO, GCSF for about 6 months. This was the third, if you noted the context, December 2021, Jan 2022, the third wave of COVID had just taken over. Although the mortality was less, but still there was a lot of confusion about what to do in a COVID scenario. So we continued her on transfusion support, supportive therapy, danazol is the standard thing which everybody in India gets if you have any of these group of diseases. Initially, she responded well, but the symptoms persisted. And then there was progressive hemolysis and abdominal pain actually worsened. So my first question is, in this kind of scenario, you got a 10% clone, but there's an ongoing abdominal symptoms. Uh, Supposing if we had a option of giving anti-complement therapy, would any of us, I mean, before I put this question to Dr. Austin, any of us, our Indian colleagues, would they go for a complement therapy? I mean, this was a patient who was completely covered by the armed forces insurance cover and anything. So Dr. Amrita or Dr. Aryant, if you had such a patient, would you go in for an anti-complement therapy, provided it was being paid for?
I think she has myelodysplastic syndrome with a 10% clone and she's young. So I think I would consider transplant over anti-complement therapy in this particular patient.
Yeah. So this is why
I wouldn't think of anti-complement therapy.
you won't. Any different opinions, Aryant?
Uh, unless she starts actively hemolyzing briskly, the retics were low, there were cytopenias. So, although I know the marrow is hypercellular, so again, a word of caution. In fact, I was thinking to put up that question. There would be few patients where there would be a morphological dysplasia in them. They are young, and probably it's because of a lot of hemolysis which is going on, and the pathologist would tend to report some form of erythroid dysplasia, which can be more than 10%. We have few on our follow-up, but they are quite young. They do not smell like MDS kind of. Their mutations are all okay. Their karyotype is okay. So sometimes you tend to be, and on follow up with just IST, their dysplasia disappears. So a lot of time the clonal MDS versus just a morphological dysplasia, I mean, that's something which we need to be cautious, I believe.
Yeah, finally coming to Dr. Austin. I mean, in UK, even if you, this is a clear cut like MDS and you would go in for a transplant, would you consider, giving a small course of an anti-complement therapy before you take up for transplant, or with a 10% clone, you don't think that there's any role for you straight away take up for transplant?
I think we would cover them with anti-complement therapy, because I think she's disproportionately hemolyzing to the degree of the PNH clone. I didn't notice what the LDH was, or whether
Yeah,
they're
LDH was around 2,500.
yeah. So I sort of, one, I wouldn't believe that 10%, or that 10% is hemolyzed in the red cell. She might have a higher PNH clone. And Arihant is quite right. Quite a lot of PNH patients get branded as MDS because PNH itself will cause dyserythropoiesis and even dysmegakaryopoiesis as well. So trying to see what it is important. But to your question, Sanjeevan, we will cover them with a short period, because we know it's a finite period to cover them around the early phase of their peri-transplant period.
Sure. So I think this is a slide which you had also had in your presentation, and going by the standard, this thing that with a 10% clone, there was a very little benefit. So we started a donor search. There was no matched family donors, and we managed to get a 9/10 donor from Datri, mud donor. However, at that point of time, put it in a context. This is a 12 or a 13-year-old girl, the family and the patient herself. She was not, no, consenting, and a 13-year-old girl was a bit of a challenge. And Dr. Rajan Kapoor faced all these issues there, and then the family didn't want to go ahead with the therapy. However, the symptoms kept on worsening a year later when she was absolutely in severe distress because of an recurrent abdominal pain. The mud donor suddenly became unavailable to donate. So, that was the paradox. So then the decision was to go in for a haplotransplant. So now that we have to go for a haplotransplant, again to my Indian colleagues first. I mean, Dr. Narinder, would you go for a marrow or PBSC in such kind of, now that you know that you got to go in for a haplotransplant? And the discussion which Dr. Rajan had initiated about conditioning, we can just skim over it again, Mac versus Rick. I think if Dr. Narinder is not there, Aryant, can you take on your take on the graft
Sorry,
source? Hi, Narinder.
sorry,
Yeah.
sorry, I'm a little distracted. So,
No, now that we are going for a haplotransplant in this young
yeah,
13-year-old kid,
yeah,
so a haplo from the mother. So
yeah.
what would be your choice for graft?
So, I mean, we have done a couple of haplotransplant for PNH, not in so much young patient, but we have used PBSC, peripheral blood stem cell graft, considering a higher risk of rejection with marrow graft in our scenario, though the data may not support it. But we have seen a higher rate of rejections with haplo when we use marrow graft in certain other diseases. So that's why we prefer to use PBSC, peripheral blood stem cell. And the conditioning, definitely RIC conditioning is preferred by us as a policy after seeing all the data showing lesser TRM with RIC conditioning, and equal or better PNH-free survival later on. So we used FB2 along with ATG, and also we have used Recently, we used fludarabine with triosulfan in RIC doses, along with a single fraction of TBI 200 grays, and the post-transplant cyclophosphamide as GVHD prophylaxis, along with cyclosporin and MMF. So that way we have done, and we found it quite tolerable, quite good for good patients. Experience were very good. Without much toxicity, and PNH clone was found to be zero later on monitoring. So that way, we have good experience with such kind of regimes.
Yeah, sure. So, Dr. Austin, in your group of patients who did undergo transplant, maybe in the pre-complement therapy, you've already mentioned to Dr. Rajan during your discussion about RIC and other things, but graft source, are you in a haplo transplant? Would you be going with a marrow or PBSC graft?
I don't know, even when the first haplo data was published and we used it for malignancies, we had gone for PBSCs. Yeah.
Okay.
And we also have the comfort of using alantusimab, which, as we know, has got a lesser risk of GVHD. Yeah. And we know in marrow failure diseases, this in PNH and other things, graft rejection, primary graft failure, and graftment is a big issue. And I think, as Narendra was saying, that the stem cell dose is quite tricky in a bone marrow source as well. So for all those reasons, when we have used Campeth as a background, as a in the conditioning for GVHD prophylaxis, we have happily gone with the peripheral blood source so that we've got more stem cells as well to prevent the risk of graft failure as well. So yes is the answer to the PBSC, and people are getting less less skilled in collecting a proper bone marrow dose nowadays. So whatever you're getting is quite low as well. So for the other reason for using PBSCs.
Sure, sure. So anyway, so Dr. Rajan did this transplant. So he used bone marrow as a graft source, but because, as the little dose was on the lower side and in a haplo we wanted, so for making up about 1 million extra dose, he used a peripheral stem cell boost the next day. The regimen was a myeloablative one, fluid blue thio with the post-transplant cyclophosphamide CSA MMF prophylaxis. And luckily, things went off well with this kid. And as you can see in the timeline, this transplant took place in March of 2024. So it's just slightly short of a year since the transplant did take place. Total CD34 dose of both the marrow and the PBSC worked out to be 5.7 million. And she engrafted on day 10 as far as the neutrophils were concerned, and day 16 as far as the platelets were concerned. Post-transplant, she had a little bit of an issue with a CNI-induced hypertension, hirsutism, but no major infections. And except for a grade 2 upper GI GVHD, which responded very well to or budesonide therapy alone, there was no major issue as far as the GVHD were concerned. So now it's 100% donor chimerism, no evidence of PNH clone. Current status is that just short of a year post-transplant, all our immunosuppression has been tapered off. There's been no rejection on GVHD. So, we had a little bit of a tough time because of the indecision and prolonging the transplant. But the learning point was that timely intervention probably was responsible for a successful haplotransplant. So this is, I think, the final outcome. It's all good. And I think Dr. Rajan has got a significant number of patients. I think he's got now, Narendra also mentioned he's got some patients of PNH on transplant. So I think it's as a group together, if we put together all our PNH transplants, especially from a country where we don't have access to anti-complement therapy, we can all put our retrospective data together and come up with decent numbers. So that's all I have to say. And thank you, Riaz, for giving this opportunity.
Hi, thanks, Sanjeevan. It was nice. So, with this, anybody can have a few questions from Austin? I think so. It's wonderful talk.
Can I just have one
Yeah,
question?
yeah, please.
Um, Dr. Austin, is it worthwhile to look at the PNH clone size on RBCs to predict who is going to have, a hemolytic course and, with more risk of thrombosis? Do you do it in your patients, or you just look for the clone on granulocytes and monocytes?
No, we
Since we
do.
do.
Yeah, so we do check on the red cells as well, because the current sort of flow cytometry guidelines is to at least check on 2 cell lines, which should be one white cell line and one red cell lineage. We do check it on red cells and either monocytes or granulocytes, but we tend to do it on all 3 cells. And sometimes because ours is a PNH center, we test it on reticulocyte as well. We check on the reticulone as well, and we do all sorts of things, but as a minimum you need it on 2 cell lines, at least red cells and one white cell lineage.
Okay, with this, thanks, Austin. Thanks very much. It was a very tough topic. It's a very small, and being in the hematology, more of us are into the leukemias, lymphomas, and myelomas. So this was the topic I was interested. So this is new. Everyone is doing in India. Some, as Sanjeevan said, few transplants are with everyone. But the anti-complement therapy, yeah, it's a welcome move if we have it in India. I think so. Then more and more patients will be getting treated for this PNH, and we will also have some data. But for that time, it's all either with some supportive care and transplants. There is a huge void in the management of PNH. I hope companies come up with this. Thank you very much for this evening. I won't wait, and hopefully we can have some more sessions of PNH soon with you. And whenever you're in India, we are most welcome. In Delhi, it's a small group of hematologists, and we'd like to host you. Okay, and most welcome. And with this, I like to close this event. I like to thanks all my speakers, Dr. Aryan, Dr. Sanjeevan, Dr. Austin, all my panelists, all my colleagues who have joined for this wonderful webinar. Thank you very much.
Thank you.
Good night.
Thank you. Good night.
Thank you.
Support team, please close the meeting.